we'll off our screen.
Okay. You get to see the attendees.
Yeah, we can see around 60 plus have joined.
Yeah, 56, right?
6. I think it's 3 p.m. now. We can begin our webinar. Good afternoon, everyone. Welcome to the weekly webinar organized by the College of Physicians Malaysia. We are back after a hiatus for around 3 months. So after all the holidays, the Chinese New Year and the Raya, I think we are back to start back this monthly webinar series. We are very fortunate to have with us two distinguished speaker and also chairperson for our neurology topic. So we are starting with a treatment update in NMOSD, and speaker today with Dr. Chew Sin Hong and the chairperson, Dr. Joyce Pauline Joseph. But before I pass the floor to Dr. Joyce, I believe Dr. Hui, the council members, have some word for us.
Good afternoon, everyone. Welcome to the College of Physicians webinar sessions, which have just resumed after a short break. This month, the series will focus on neurology, so there'll be 4 sessions. I'm glad to say a few words about the College of Physicians Malaysia. The college is a professional body registered with Societies Act under Registrar of Societies. It comes under the umbrella of Academy of Medicine of Malaysia, and all physicians who join the academy automatically become members of our college. The college is active in education and training and runs MRCP exams for the parallel pathway. It is also the voice and advocate for physician causes. I want Afiq to share his little slideshow. It is a view of our new academy building. We are newly housed in academy building. The address is unit 3.7, level 3. Not all that is ours. We only got 1 unit. Medical Academies of Malaysia, number 5, Jalan Kepimpinan, P8H, Precinct 8, 62250 Putrajaya. So that's the address. The annual scientific congress this year will be held at the new Academy building in Putrajaya from 1st to 3rd August 2025 and will be officiated by HRH Sultan Nasrin Shah. Apart from main scientific conference, there will be quiz sessions for Kukalin Cup, conferment of fellowship, lifetime achievement award, and an acute medicine course. Hope many of you can come and attend this conference. Thank you.
Thank you, Dr. Hui. Without further ado, I pass the floor to Dr. Joy Joseph. Hi, Dr. Joyce.
Hi, everyone. Welcome to this webinar where we'll be talking about demyelinating diseases. And our speaker today is Dr. Chew Sin Hong. So Dr. Chew is a consultant physician as well as consultant neurologist in Sultana Amina Hospital, Johor Bahru. So Dr. Chew had done his neurology training in Queen Elizabeth Hospital, Kuala Lumpur, as well as Gold Coast University Hospital in Queensland, Australia, where he did some training in neuroimmunology diseases. So his other posts are he's an EXCO member for neuroimmunology and neuroinfection chapter in the Malaysian Society of Neuroscience since 2023. He's the secretary of Johor Bahru Neuroscience Society, and he has done quite a few clinical trials and has got various publications. Dr. Chew, in my knowledge, has shown quite keen interest in neuroimmunology. And from what I remember, he has always been one of those who's always asking questions in any neuroimmunology events. So without further ado, I now introduce Dr. Chu Sin Hong to start his talk.
Thank you, Dr. Joyce, for your kind word. Can everyone hear me? Okay, I'll share the screen. Okay. So a very good afternoon, ladies and gentlemen, and all my colleagues. I'm Dr. Chiu Sin Hong from HSAJB. So today, without further ado, I'd like to share with you this topic of treatment updates in NMOSD. So NMOSD stands for Neuromyelitis Optica Spectrum Disorder. And this will be the overview of my presentation. We'll talk about a bit about this disease, its presentation, and also the diagnostic criteria. But the main focus of my presentation today will be on the treatment. So will be based on acute and also maintenance treatment. Very importantly, we also touch about pregnancy issue and also other emerging therapies. So NMO was first described by Dr. Eugene David in the year of 1894 in this paper called Neuromyelitis Optica, where they described classical cases of NMO. But it wasn't until 100 years later that this aquaporin 4 antibody was finally identified by Venna Lennon, and using a cell-based assay, that's how it paved the understanding of this disease and all the neurosciences. And since then, we have gained a lot of understanding about the pathogenesis of NMOSD. So if you could, if you look at here, so first of all, the aquaporin 4 antibody will be synthesized in the serum and enabled by this interleukin-6 cytokine to penetrate the blood-brain barrier into the CNS compartment. So aquaporin 4 antibody will bind to the food process of the astrocyte. This will activate the classical complement cascade, and this will causing us complement-dependent cytotoxicity. This triggers inflammatory response with the recruitment of all the inflammatory cells into the CNS, including neutrophil, monocyte, and also eosinophil. And all this inflammation will damage the astrocyte and causing the loss of support for oligodendrocyte. And as we know, this oligodendrocyte is important for myelination of the axon. So this will cause a demyelination disease. So in short, NMOSD has been described as a primary astrocytopathy with secondary demyelination. So the diagnostic criteria of NMO has also evolved over the years. So in the classical Davick's NMO cases in 1894, he described the patient as having optic neuritis, myelitis with no brain lesion. In 1999, the Mayo Clinic tried to refine this criteria. So patients have optic neuritis, and the myelitis should be longitudinal extensive transverse myelitis, more than 3 vertebral segment long, and shouldn't be any other CNS disease. In 2006, after the discovery of aquaporin 4 antibody, so they further refined the criteria. So patients should have LETM. They also realized that some of the patients with NMO has brain lesion that doesn't meet the criteria for multiple sclerosis. In 2017 and 2007, they also included other brain syndrome. However, the standard criteria was only proposed in 2015 in the International Panel of Diagnostic Criteria. So in this 2015 criteria, they divided patient into either aquaporin 4 positive, then you only need one core clinical characteristic, which can be optic neuritis, myelitis, or brain syndrome. Or if you have unknown status of aquaporin 4 or aquaporin 4 negative, then you will require 2 or more core clinical characteristics with supporting MRI criteria. So what are the core clinical characteristics that in NMO? So basically, these are the 6 most common presentation of NMO. So first of all is optic neuritis. It's probably the most commonest presentation. Typically, patient can present with bilateral optic neuritis, and the MRI can be totally normal, or it show at least half of the optic nerve involvement with chiasm involvement. Second is transverse myelitis, and the MRI typically show longitudinal extensive transverse myelitis with more than 3 vertebral segment involvement. Number 3 is a special condition called area syndrome, where a patient can present with intractable nausea, vomiting, and also hiccup. An MRI typically show lesion in the dorsal medulla center, which is the emetic center of the brain. So if you ever encounter a patient with intractable vomiting, persistent vomiting of more than 2 weeks, and there's no any GI causes found, then perhaps you should consider this patient as having an NMOSD. So the first 3 symptoms are called the classical attack of NMOSD, which are the most commonest presentation. Number 4 is other brainstem syndrome, where patient can have lesion in the periependymal area. Number 5 is also another peculiar thing called symptomatic narcolepsy or acute diencephalon syndrome. So MRI typically will show lesion in the thalamus, causing patient to be drowsy, or they can also have lesion in the hypothalamus, causing patient to have endocrine problem due to pituitary dysfunction. Number 6 is perhaps the rarest form of presentation, where patient can have symptomatic cerebral syndrome, where they can have very large tumefactive lesion in the cerebral hemisphere. So to illustrate this, there's a few MRI. So you can see in the top panel here, these are patients with MRI of the spine and showing longitudinal extensive transverse myelitis. So you can see the lesion was quite long all the way until towards the end. And the lesion is typically central, occupying the whole cross-section of the spinal cord. Typically, they are also upper cervical involvement, and you can see cord expansion here. And sometimes it can also extend all the way up to patella. And this lesion sometimes it can be seen as what we call a flame-shaped lesion. And in the lower panel, you can see orbital MRI, where you have patient has longitudinal extensive optic neuritis over here, and also the involvement of chiasm. And in this top panel, you can see patient with area syndrome, where they have lesion in the dorsal medulla over here, here, and here. Okay. And here, this is another lesion in the dorsal medulla, and this patient also have a lesion in the ventral medulla. And patient can also have other brainstem lesion, where they have this periependymal lesion in the dorsal midbrain and also around the fourth ventricle, where they are very rich in aquaporin 4 channel. So again, just to recap the 2015 IPND diagnostic criteria, if you have a positive aquaporin 4 antibody, you only need 1 core clinical criteria. If you have negative aquaporin 4 or unknown status, then you need at least 2 core clinical criteria. One of them must be the classical type, and it also have supporting MRI features. So based on this diagnostic criteria, we are able to diagnose NMOSD even though we do not have a positive aquaporin 4. So as I mentioned, you need at least 2 core clinical criteria, which is consistent with the phenotype of NMO. And we already now know that some of these cases, about 25% of them are in fact Morgag disease. However, there are still the rest of the patients are actually negative for both NMO and MOG antibody, what we call a double seronegative cases. So these are quite a heterogeneous cohort of patients in terms of etiology and pathophysiology. Some of them may be monophasic and they are less female predominance, and some of them we may not even sure they are actually immune mediated. We'll talk about the treatment of seronegative later. So this is the main focus of our presentation today. We'll talk about acute treatment. So once a patient presented with a symptom consistent with NMOSD, acute treatment must be initiated as soon as possible after we exclude infection. So sometimes you may not able to get the aquaporin 4 antibody result back in time. So you have to start treatment even before you have a confirmatory antibody. So treatment option for acute therapy include high-dose corticosteroid therapy. Typically, we give IV methylprednisolone 1 gram for 3 to 5 days, or apheresis therapy. This will include plasma exchange or immunoabsorption. So basically, plasma exchange is something, the principle is similar to what we usually do in dialysis, where the patient blood is actually we actually insert a dialysis catheter either in the femoral or IJC, and the blood was actually go through the blood pump and go to a plasma separator or a filter. So this plasma separator will separate out the plasma and also the immunoglobulin-rich serum. So this serum will be discarded containing the aquaporin 4 antibody, where we then will substitute with the protein-rich fluid such as FFP or 5% fulminant albumin. And all this will be returned to the patient. So in the process itself, we'll remove the aquaporin 4 antibody. So the benefit of apheresis therapy is the highest in those who begin therapy early. As you can see in this study, those who begin plasma exchange within 0 to 2 days, 40% of them actually achieve complete recovery, compared to those that begin more than 1 week later. Only 3.7% of them has full recovery. So as such, we try to recommend plasma exchange or apheresis therapy as soon as possible, and sometimes even as a first-line treatment. So especially patients that presented with severe myelitis, if patient has insufficient response to steroid in the previous attack, or patient have very good response to plasma exchange in the previous attack. So plasma exchange is typically carried out every other day for 5 courses, but sometimes you can actually prolong the treatment course until 10 courses. So this will actually improve the outcome and lower the number of non-responder. So basically, this is just a treatment algorithm to summarize what I have talked about acute treatment. So basically, when patient presented with an acute attack of NMOSD, you can start the patient on IV methylprednisolone 1 gram per day for 3 to 5 days. If patient doesn't respond very well, you can give them plasma exchange, either 5 to 10 cycle. You can do it EOD or daily. And at the same time, you can also add on concurrent methylprednisolone together with plasma exchange. So after the methylprednisolone, we should give the patient a tapered dose of prednisolone over 3 to 6 months to prevent subsequent attack, especially at the start or the switch of long-term immunotherapy. There are also other experimental treatment for acute treatment, including IVIG, early use of anti-CD20 therapy, early use of anti-complement therapy, and antibody against neonatal Fc receptor. So these are drugs like efgartigimod, which has been called as a chemical plasma exchange agent. So IVIG itself has quite limited evidence, and they are all mainly based on case series. So we have from Margrainer in 2013, with 8 patients with NMOSD, was given IVIG regular infusion and follow-up 19 months, reduced in ARR from 1.8 to 0.06. So ARR is the annualized relapse rate of NMOSD. So basically what it means that if, let's say, if your patient have 1 relapse in a year, then ARR will be 1. Okay, so you take the total number of relapse divided by the number of year, then you get ARR. If the patient have, let's say, 4 relapse in 2 years, then the ARR will be 2. So you can see that the ARR, the relapse rate in the year, actually reduced from 1.8 to 0.06, which is quite a significant improvement. And we also have our local study by Dr. Shanti in 2015, where 6 patients with NMOSD were followed up for 4 years. So they were given induction dose of IVIG followed by regular infusion every 2 to 3 months. So the number of relapse were reduced from 8 to 1. The ARR was reduced from 0.75 to 0.15. This is statistically significant. However, there's no improvement in terms of EDSS. How about the maintenance therapy? Okay. So we now know from multiple studies that NMOSD is a universally relapsing cause. So without treatment, patients with universally, they will relapse and get worse. So treatment with maintenance is important to help prevent attack and disability accumulation. Before the year of 2019, the treatment are basically empirical and based on retrospective study. So these are treatment agents that we commonly use that we are currently still using. So azathioprine, mycophenolate, rituximab, with or without steroid. So I'll talk about azathioprine, which is the most commonly used agent in KKM. So basically, in this study by Constanzi in 2011, so they have 70 patients with NMOSD, seropositive. So after given the treatment of azathioprine for at least 12 months, 31% of patients become relapse-free. Unfortunately, this will mean that more than 66% of the patients still suffer from a relapse despite treatment on azathioprine. So the common side effect documented will be nausea, vomiting, and GI side effect, and patients also suffer from leukopenia. And on long-term follow-up, there are 3 cases of lymphoma documented. As we know, long-term immunosuppression with azathioprine has a risk of malignancy. So in a subgroup analysis, they analyzed patients according to who actually become relapse-free, and they noticed that if you give patient azathioprine at a dose of more than 2 milligrams per kilogram, the ARR is 0.52, as compared to if you give them a lower dose, the ARR is actually 0.82. That's why in our current guideline, we recommend that if you are giving azathioprine, you need to titrate up the dose between 2 to 3 milligrams per kilogram. The other predictor of good outcome is they notice if they have a change in MCV of more than 5 from baseline. So for example, if your MCV before starting therapy is 90, and after a year of azathioprine, if it's more than 95, then your patient is more likely to be responsive to azathioprine. So azathioprine as a very commonly used immunosuppressant in various subspecialties, it is important that we know a bit about its metabolism. So azathioprine is a prodrug that is converted to 6-methylpurine, and after that there are 4 metabolic pathways. So the first 2 is xanthine oxidase and TPMT. They will be converted into this inactive metabolite, which can cause hepatotoxicity. There's another pathway called aldehyde oxidase, and also the final pathway is conversion into 6-TGN, which will act in the marrow to suppress the lymphocyte and that's where the clinical efficacy comes from. Okay, so first of all, based on population study, we already know that there are some patients that have a mutation in their TPMT gene. So about 89% of our population is actually have normal TPMT enzyme, which convert 6-methylpurine into other metabolite. But if without this, if patient have a mutation, whether have homozygous or heterozygous, meaning that they will not able to process this 6-methylpurine, so all of this will be converted to 6-TGN. So patient will have a very profound bone marrow suppression. So if you are starting a patient on a low dose azathioprine and notice as patient suffer from a profound leukopenia, then you might need to consider checking TPMT. Unfortunately, this is not a routine practice in the public hospital, or consider this patient should be switched to other form of immunosuppressant. So the other thing I want to pay attention is this xanthine oxidase, and if you can recall, this is also the same enzyme that's being used that's being inhibited by allopurinol. So this is a very serious drug interaction. If your patient is taking allopurinol for gout, then you shouldn't put the patient on azathioprine, as you inhibit this pathway, and this again, it will cause profound myelosuppression as well. Rituximab is another commonly used medication. It's a chimeric murine enhalement anti-CD20 monoclonal antibody. It can help to deplete both naive and memory B cell. The first case series is published by Cree in 2005. Rituximab helped to reduce ARR from 2.6 to almost 0 in 8 patients, and 75% of them remains relapse-free at 12 months. So the typically dose given was usually 1 gram at day 5 and day 15. This is the induction dose. And the other alternative is 375 milligram per meter square weekly for 4 weeks. The maintenance dose is usually 1 gram after every 6 months. So you can give a fixed dose dosing, or you can choose to monitor the patient's CD19 count. If it's more than 0.1% of all lymphocyte or more than 10 cells per microliter, then you can start to redose the patient with rituximab. This is the first randomized controlled trial using rituximab in NMOSD called RIN1 study that's carried out in Japan. This involved 38 patients who are aquaporin 4 positive. So they all started with rituximab with 2 weeks induction, followed by 6 weeks of regular infusion. And both groups are given 8 weeks of prednisolone in the beginning. As you can see, after they off the prednisolone, the graphs start to diverge very fast. And after they follow up for the 72 weeks, there's 37% relapse rate in the placebo group compared to 0% in the rituximab group. And the side effect was fever, headache, which are usually manageable. And in this meta-analysis of rituximab, you can see that the final weightage actually favor rituximab. So in the combined meta-analysis, it showed that rituximab reduced the ARR by 0.79 and also reduced the mean EDSS score by 0.64. And there's no significant adverse effect, as I mentioned. So most of the time, patient may complain of infusion-related adverse event, about 10% of them, like headache and pruritus, which can be managed by pre-medication. There are some report infection, and so some patient may suffer from leukopenia, and sometimes it's important to monitor patient full blood count after infusion of rituximab, as sometimes this leukopenia can be delayed in onset. Very importantly, in this case series, there's no cases of progressive multifocal leukoencephalopathy, which is a very severe effect of immunosuppressant in the brain. So this is just a table to summarize all the classical treatment for NMOSD. Maybe I can enlarge the slide for you. Okay, as we can see, azathioprine typical dose is 2 to 3 mg per milligram per kilogram. Okay, what I want you to pay attention is the speed of onset of this medication. So azathioprine, the full onset of action only can be seen after 6 to 12 months, as compared to patient on mycophenolate, typically within 8 to 12 months, and rituximab usually takes place between 8 to 12 months. So you can see azathioprine actually have a very delayed onset of action. Even when patient was on full dose of azathioprine, you probably can only see the effect after 6 months. That's why it's important that this patient after acute attack, you need to give patient glucocorticosteroid up to 6 months in order for the azathioprine to take effect. So mycophenolate, the dose is usually 500 to 1 gram twice a day. So the onset is usually within 3 months. The side effect includes same thing, anemia, liver enzyme problem, and also GI side effect as well. There's also a concern about increased cancer risk, and very importantly, mycophenolate is also teratogenic. So this medication should be avoided in female in childbearing ages. So how does all the three medication compare with each other? So in this study that's published in 2014, where they compared these 3 agents in the treatment of neuromyelitis optica. So the total of 90 patients follow up for 40 months. As you can see, azathioprine has a 53% rate of failure despite concurrent use of prednisolone. Mycophenolate about 36%. Rituximab is 33% in total and 17% on optimum dose. So if we take rituximab as a reference point, you can see that the hazard ratio for mycophenolate is 1.48 and for azathioprine is 2.12, meaning that if you're on azathioprine, you are twice as likely to have a relapse compared to rituximab. So this is actually quite suboptimal. So 2019, we've seen many major advances in the treatment of NMOSD. So it has been also called as the year of NMOSD. So we'll go through this few major landmark trial in the treatment of NMOSD. So this is just a diagram to simplify the 3 agents that I'm going to mention. So inebilizumab is an anti-CD19 monoclonal antibody which depletes aquaporin 4 producing plasma cell. Satralizumab and tocilizumab interfere with interleukin-6 signaling. Eculizumab is a C5 inhibitor and it prevents complement activation. So we know from basic science study that interleukin-6 is actually quite elevated in active NMOSD, both in the serum and also CSF of patient. And compared to patient with MS and other demyelinating disease, so you can see that only NMO has elevated IL-6. This IL-6 also been shown that it promotes aquaporin 4 production and also secretion from B cell. It increased blood-brain barrier permeability and allowed the penetration of this antibody into CNS. And if you block this IL-6 receptor, you can actually reduce the survival of plasmablasts in vitro. So with that in mind, we already have an agent, which is tocilizumab, which is a IL-6 inhibitor. So people start to experimenting with tocilizumab and see how do they work in NMOSD. So we have, so these are 8 aquaporin 4 positive patient NMOSD that resistant to azathioprine and mycophenolate, which is given tocilizumab 6 to 8 mg per kilogram infusion every 28 days. As you can see in the final result, after a follow-up of 40 months, there's ARR reduced from 4.0 to 0.4. This is actually quite a very significant improvement. Median EDSS decreased from 7.3 to 5.5. And the other biomarkers that they measure is aquaporin 4 titer and also the pain level also reduced significantly in the treatment. So based on this study, we now know that prolonged and regular use of tocilizumab is safe and effective for the treatment of NMOSD. So based on this success in the study, so the drug company has come up with this designer drug, what we call satralizumab, which is also an IL-6 inhibit blocking agent that have 4 times longer duration of action than tocilizumab. So the landmark trial for satralizumab, the first one is called Sakura Sky, where patients are randomized into satralizumab or placebo. So this satralizumab is given subcutaneously, 120 milligram at 0 to 4 weeks, and then every 4 weekly. The main inclusion criteria patient must be between 12 to 74, so they included a teenager patient as well, and both of the group of the patient are on baseline immunosuppressant, including azathioprine, mycophenolate, and also corticosteroid. So you can see from this Kaplan-Meier curve that so the result diverged very fast. So in patient, so when added to this baseline immunosuppressant, which is azathioprine and also mycophenolate, satralizumab actually reduced the risk of relapse by 62%. And if we only consider the aquaporin 4 cohort, this number is even more impressive, 79%. If we only consider the aquaporin 4 negative, it's only 34%. And the adverse effect is quite similar to placebo, indicating that this drug is actually quite safe. So after the Sakura Sky, so you already reach the sky, then you aim for the star. So this trial is basically the same design of RCT using satralizumab, but this time they are aiming for a monotherapy, meaning that patients are not on any other immunosuppressant. So same thing, patient are randomized to satralizumab or placebo. And you can see that overall group, so the hazard ratio is 0.45. So there's a reduction of relapse rate by 55%. And if we only consider the aquaporin 4 positive group, the reduction is 74%, which is even more impressive. But if we look at the aquaporin 4 negative cohort, the hazard ratio is 1.19, which is not significant. So this is actually a negative trial for this seronegative cohort of patients. Second agent is inebilizumab. So basically, this is a monoclonal antibody against CD19. So we know that CD19 is actually a cell surface antigen on the B cell that is. So if you have that is actually more widely expressed on the B cell. So you have rituximab like CD20, they only cover this portion of your B cell from immature until memory B cell. But if you're in inebilizumab, if it's a CD19 antibody, it will target the plasma cell and also the plasmablast as well. So the landmark trial for inebilizumab is what we call N momentum study. So patient was randomized into inebilizumab and also placebo. So the inebilizumab dosing is quite similar to rituximab, where they are given 300 milligram at day 1 and day 15, and then repeat after every 6 months, 300 milligram. So we can see in this study that in inebilizumab, actually the hazard ratio is 0.27, so meaning that it reduced the relapse rate by 78%. And in the Acute 4 cohort, this number is even better, so it reduced the relapse rate by 79%. And in the graph, they notice that there's significant B cell depletion that can be observed within 4 weeks of dosing, and it remain low until the point of undetectable throughout the study. So patients with B cell count that consistently less than 5 cells per microliter are the least likely to have attack in the open label extension compared to those that have rebound in their B cell count. And the rate of neutropenia recorded in this study is about 2%. So the third agent is eculizumab, which is Soliris. And this is a humanized antibody against complement C5 that prevent the cleavage of C5a and C5b. It's also been approved for treatment of PNH, atypical HUS, and also myasthenia gravis. So we know C5a is pro-inflammatory and C5b induce the formation of membrane attack complex, which actually damage the astrocyte. So in the landmark trial called PREVENT study, patients were randomized into eculizumab or placebo. The dosing of eculizumab is 900 milligram weekly for 4 doses and followed by 120 milligram every 2 weeks IV infusion. So you can see the Kaplan-Meier curve actually will diverge very far and wide. So even at the beginning of the therapy, so on patient that are given eculizumab, only have 3% have relapsed compared to placebo of 43%. The hazard ratio is 0.06, meaning a reduction in relapse rate by 94%. And in the subgroup analysis, so about 75% of the patient actually also still on baseline immunosuppression, either azathioprine or mycophenolate. So the rate about 4% and some of the patients are monotherapy, where they only given eculizumab without any immunosuppressant. The relapse rate is 0. So you can see this number is actually quite impressive by 0.02, meaning a 98% reduction in terms of relapse rate. In fact, this is probably the most stunning result that we ever seen in neurology or even in medicine. A medication that can reduce relapse rate up to 98%. The main concern about eculizumab is patient may have higher risk of meningitis. So all patients receive meningitis vaccination before the trial, but there are still about 3.3% of patients that develop meningitis despite the vaccination. So as I mentioned just now, eculizumab is a very effective drug, but unfortunately the dosing is quite troublesome, where you have been giving patient have to be given eculizumab every 2 weekly. So this is quite a troublesome regime. So the same drug company actually engineered another medication called ravulizumab, which is the same C5 inhibitor, but have 4 times longer the duration of action. So this is published in the Champion Trial 2013, where there are 58 seropositive patients, which are highly active for more than 1 relapse in a year. So in this trial, some of the patients are monotherapy, some are combination therapy, where they are also on azathioprine or mycophenolate. As you can see in this Kaplan-Meier curve, so in patients that are on placebo, there are a lot of relapse, whereas in ravulizumab group, the ARR reduction is actually 98.6%, which is another stunning figure. Another more impressive subgroup is about 36% of this cohort of patients actually previously have failed rituximab therapy. So they have enrolled this group of patients, and they show that in this cohort of patients, 93.7% of them become relapse-free. So meaning that if your patient failed rituximab previously and is considered highly refractory, you can still use ravulizumab to treat the patient. And in this champion study, there are 2 cases of meningitis, which is a similar rate of 3.4% compared to the eculizumab trial. So how do we compare all these novel monoclonal antibody? So as you can see, eculizumab and ravulizumab both are highly effective with reduction of relapse rate more than 94 to 98%. Satralizumab include quite a lot of seronegative patients, and it can be given as a monotherapy or a combination therapy with other immunosuppressant. Inabilizumab is mainly only given as a monotherapy, and the rate of reduction, the rate of relapse reduction is 73%. So again, this is just a table to summarize all the monoclonal antibody. If I magnify this, what I want you to pay attention is the rate of onset of this medication. As you can see, in eculizumab, similarly like rituximab, you probably have full onset of action after 6 to 8 weeks. Eculizumab and ravulizumab has almost immediate effect within 1 or 2 weeks. That's why some of the author actually recommended that eculizumab can be given as a acute treatment as well in NMOSD attack. Tocilizumab about 3 months, and satralizumab is also about 3 months. So we have mentioned so many drugs to treat NMOSD, and they are all quite effective. Which one should I choose? So this is just a table to summarize all the treatment that we have for NMOSD so far. As you've already heard from my previous explanation. So eculizumab and also ravulizumab have the highest efficacy and also the most rapid onset of action. Unfortunately, such a ideal drug also comes as a very high cost. So the cost of eculizumab is about 700,000 ringgit per year. So this is almost close to 1 million per year. So the second best treatment that we have is rituximab in eculizumab. So the onset of action is a bit intermediate, followed by satralizumab as well. So intermediate onset of action, probably within 3 months. Reasonable efficacy, but the cost is still very high. So our traditional treatment, azathioprine and mycophenolate, the efficacy unfortunately is very low. The onset action is very delayed in azathioprine, more than 6 months. The only good thing about them is they are oral medication and the cost is very low. So we have so many wonderful drugs, but how do we put them in a treatment algorithm? So this international panel came up with a consensus on how we should use this highly active monoclonal antibody in NMOSD. So they mentioned that it can be given as a first-line therapy if cost is not an issue, or it can be given as a second or third-line therapy after failure of traditional immunosuppressant. So we need to take into consideration what are the efficacy they were looking for, what's the administrative route, what's the interval dosing, and also patient preference. If a patient is stable on current oral immunosuppressant, there's no need to switch. But if not, then we should consider giving the monoclonal antibody. And always we try to give patient monotherapy because it can reduce the side effect of concomitant immunosuppressant. We should monitor closely for infection. So things like COVID and other viral infection or flu, these are still preventable. If adolescents with NMOSD, the only indicated treatment is satralizumab. We have very limited data in pregnancy. I'll talk about that later. And all patients on eculizumab should receive meningococcal vaccine before starting this treatment. So this is just a treatment algorithm to summarize what I've talked about. So in alpha-4 positive NMOSD, usually we start with azathioprine or mycophenolate or tocilizumab. And if they fail this oral agent, then we will switch them to monoclonal antibody. You can start with rituximab or any other monoclonal antibody. Most importantly, if you are switching them after they fail one monoclonal antibody, then you should consider a monoclonal antibody of different mechanism of action. For example, if they already fail rituximab or inabilizumab, then you should consider maybe a complement inhibitor. vice versa. And if patients see a suboptimal response, then you might consider a combination therapy, either adding the monoclonal antibody together with this oral treatment, immunosuppressant like azathioprine or mycophenolate. So these are 3 types of vaccine available in Malaysia for meningitis. So basically, they are all quadrivalent active, ACU, W, and Y. So what about the seronegative NMOSD, which is double negative? So typically, we still give them either azathioprine or mycophenolate, and sometimes we also give them rituximab or tocilizumab. However, there's no trial, as you can see before, that conclusively proven to treat NMOSD seronegative. How about family and pregnancy? So before pregnancy, ideally, you want to select a therapy that is safe for pregnancy. For example, rituximab, azathioprine, and also eculizumab. These are safe, and we try to avoid teratogenic therapies such as mycophenolate and methotrexate. So patients should be counseled on the use of contraception until their disease is stable for at least 1 or 2 years and update their vaccination. Once they got pregnant, so based on study, we know that the risk of relapse is quite similar to the rate before pregnancy. But if some patients choose to withdraw or stop their treatment, then they may have a higher risk of getting relapse. So they should definitely be counseled to continue their therapy. Based on case report, we also know that the risk of miscarriage is somehow higher in patients with NMOSD based on various reasons. So if patients do suffer a relapse during pregnancy, corticosteroid and plasma agent and IVIG are all safe in pregnancy. Postpartum, there's actually an increased risk of relapse, so it's important that patients continue their immunosuppressant. Breastfeeding is safe for rituximab, azathioprine, and also prednisone, likelihood of C5 inhibitor as well. So this is just another table to summarize the treatment that are safe and also not safe. So as I mentioned, the red one are not safe for pregnancy, like cyclophosphamide, methotrexate, or mycophenolate. The safe one will be prednisolone, azathioprine. Some evidence for tacrolimus and also eculizumab. There are some emerging therapies as well. We are just going to quickly go through them. So basically, we already know the pathogenesis of NMOSD. That's how we can come up with all this scientifically targeted therapy for NMOSD. And the diagram just get more and more complicated over time. Now we discover more and more pathway that we can target other than the traditional drug that I mentioned before. And finally, we have come to this stage that we have multiple targets that we can target in NMOSD. So we already seen IL-6 inhibitor, CD20, CD19. There's also trial on glutamate antagonist. So we'll talk about other treatment like aquaporin 4 blocking agent and also anti-neutrophil therapy. So we now know that NMOSD is caused by aquaporin 4 antibody. So why not we block the antibody altogether so that it will not cause any disease? So this is the rationale behind aquaporumab, which is a non-pathogenic version of aquaporin 4 antibody. Basically, it will bind to the aquaporin 4 channel and displace the pathogenic version of the antibody. This actually causes a marked reduction of aquaporin 4 cytotoxicity. So basically, you have a fake aquaporin antibody that binds to the channel so that the real aquaporin antibody cannot bind. These are still in vitro model. The other way that the researcher has came up is they noticed that some pathogen like strep pyogen, which is a common bacteria, actually have produced enzyme that can inactivate immunoglobulin and causing sepsis. So they actually engineer this enzyme called IDS and ENDOS that can selectively inactivate aquaporin 4 IgG by their degrading enzyme, therefore destroying the aquaporin 4 antibody. Other complement therapy, including C1 therapy called Cinryze, that can also help to inhibit complement C1. So other anti-granulocytes. So as we seen just now, so this is also part of the inflammatory pathway in NMOSD. So Civelestat is actually an anti-neutrophil medication that can help to reduce proteolytic activity and also inflammatory cytokine in the CNS. He has completed phase 1b study. There's also some evidence for anti-eosinophil therapies, simple things such as antihistamine or cetirizine. So this is actually an open label study of an trial of cetirizine. So there are 24 patients with NMOSD. So patient has been stable on their baseline immunosuppressant for 18 months, and they give the patient additional cetirizine to be taken daily and follow up for 1 year. And it's quite remarkable that they actually reduced the ARR from 0.4 to 0.1, and the EDSS remains static. So this is actually it actually shows that if your patient still have uncontrolled disease, you can just add on simple things just like cetirizine to help them to improve their response to NMOSD. So in conclusion, so we now know, okay, so basically this is just a recap of what I've talked for the past one hour. So the current NMOSD treatment include corticosteroid and also plasma agent in acute treatment, maintenance treatment, rituximab, azathioprine, and mycophenolate. And we now have approved, FDA approved targeted therapy for NMOSD, including eculizumab, inebilizumab, and satralizumab. Potentially new target will be aquaporumab, okay, this inactivating enzyme, and also C1 inhibitor, and also anti-neutrophil therapy as well. However, there's still a lot of challenges in NMO and therapeutic, including how do we compare all these treatments? Should everyone be started on the most expensive medication, or how do we optimize the treatment? What are the biomarkers to monitor the patient to know that whether they are responding to treatment or not? Is there any treatment for remyelination and restore the patient function? And also, there's still one big mystery, which is the seronegative patient. How do we properly manage them? Okay, so with that, I'd like to end my presentation. Thank you very much for listening. We welcome any question.
Thank you, Dr. Chu. Let me just get my video. So thank you, Dr. Chu. There are a few questions for you. Dr. Harris Ngao has asked, what is the epidemiology of this disease and gender predominance?
So the epidemiology of NMOSD actually vary quite a lot across the globe. So we know that this is actually a disease that predominantly affect the Asian and also the Hispanic. In the original series of David disease, they also noticed the same trend as well. And previously, this is also known as the optical spinal MS that is most prevalent in Japan. So this is basically a very Asian disease, and also very highly female predominant. So the ratio can be up to 1 in 4, and in some study it can be up to 1 to 6. So meaning that you have 1 male to 6 female ratio.
So do key in your questions in the Q&A box, please, to Dr. Chu. We still have a few more minutes. So another question is how to differentiate multiple sclerosis from NMOSD for patients first presenting with optic neuritis.
Okay, so this is another huge topic. So, but basically, there are many criteria that can help us to differentiate between NMOSD and also MS. So first of all, usually let's say in the case of optic neuritis, in MS, usually they are unilateral. If you have bilateral onset of optic neuritis, they are usually NMOSD. So, and the attack in NMOSD is usually more severe compared to MS as well. So patient can get a visual acuity of less than 1 in 60 in NMOSD attack as compared to patient with MS. So other paraclinical criteria also help us to differentiate between the two diseases. So basically from the MRI scan as well, usually the involvement of NMOSD is actually more severe, where they can have longitudinal extensive involvement of the optic nerve. They can involve the optic chiasm, as I mentioned before. As compared to MS, usually they are very short lesion in the optic nerve, or sometimes it can be totally normal in the MRI. And the most easiest way to differentiate the two is you can check the alcohol-4 antibody. If it's positive, then it means that patient have NMOSD. And if it's negative, then it's still possible you need to consider multiple sclerosis.
Thing to add to Dr. Chu is optic neuritis in NMOSD is more posterior and in MS is more anterior. And also the recovery can be poorer in NMOSD and MS. So now let's go to the other questions. Do we check aquaporin 4 antibodies in serum or CSF or both? Which one is better?
So basically, as I mentioned before, it's mainly produced in the serum, in the plasma cell. So basically, the most accurate way is actually checking the serum. And so far we do not have evidence to show that CSF antibody is reliable in any sense. So most of the time we still only check the serum.
I agree with Dr. Chu. The serum assay is better in whichever assay that we do. And also, I think in Malaysia, serum is more accessible. So there's another question, a long one. Message to the audience, if you do have questions, please drop them in the Q&A box for Dr. Chu. So the next question is, I have a seropositive NMOSD lady. Initial acute phase completed IV methylprednisolone and completed rituximab 6 monthly for 2 years with concurrent low-dose prednisolone. No intermittent flare in between since rituximab was given. Added on azathioprine as maintenance therapy, but patient has GI upset, thus has defaulted the azathioprine dose. Can only tolerate up to 12.5 of azathioprine. Patient keen to conceive and currently on implanon. In terms of long-term immunosuppressive dose, do we give the patient rituximab? I think what she means is, do we give the patient another dose of rituximab if CD19 level proved less than 0.1% in upcoming June 2025? Or we switch to MMF with effective contraception, telling patient not suitable to conceive first, or we keep low-dose prednisolone enough?
I think this is a very clinically relevant question, and thank you for asking. So basically, if your patient has been doing quite well with rituximab, it's in fact this medication is actually have evidence to show that it's safe throughout pregnancy. So what we usually do if a patient is stable on rituximab, you can actually give the patient one dose, and then patient after about 1 month or so, patient can actually start to plan for conception. And let's say if the CD19 remains quite suppressed, you can actually extend the dosing up to after pregnancy. So basically, you give one dose right before they get conception. And throughout the pregnancy, we do not redose them again. If the CD19 remain quite low, less than 0.1%, and you only redose them after they give birth about within 5 weeks. So this has been proven. This has been the strategy being used also in multiple sclerosis patient as well. So I would not recommend patient to switch on other therapies since that the patient has been doing quite well on rituximab, and in fact we have more evidence to show that all rituximab and this therapy actually is quite safe for pregnancy and also in breastfeeding.
Okay. So the last question in the box, remember you can still ask us a few more questions if you want. Any local lab capable of doing the seromarker aquaporin 4 antibody?
So yes, our IMR does provide service for aquaporin 4 antibody. So you can there's actually a form that you can download online. Even in the KK setting or other GP setting, you can also request for this test. Can send to IMR. The other facility that provide is in LabLink. So there actually are many other private lab that provide this service as well. So so far this the result has been quite accurate. So all the aquaporin 4 tests, usually they are highly specific. Once they are positive, they usually means patient have NMOSD.
Yeah, it's quite easy to do. I mean, I'm not sure in the government, is IMR still doing too?
Yes.
From Johor, where do you send them?
So basically, if a patient can afford to pay, we'll send to private lab such as LabLink. They usually the turnover time is about 1 to 2 weeks. We send to IMR, sometimes the turnover time is about 1 month, which is a bit prolonged. But regardless, what I want to emphasize in my talk is even if you had not get the result aquaporin 4, if a patient presented with symptom consistent with NMOSD, you should start the treatment immediately while waiting for the result and cover the patient with steroid until you receive the antibody result.
Yeah, it's quite easy to do. So we can send it to IMR or to any of the private labs. So those were the questions. But before we end, I have a few questions, Dr. Chu. So in your experience in Queensland, did you see NMOSD frequently? And I know that was a few years back. And what is the modality of treatment chosen by the neurologist there?
So we do see a few NMOSD in Australia, but as I mentioned, most of them are Asian in heritage. So in Queensland, usually the approved treatment, the first line treatment that they give is rituximab. In fact, I think most of patients doing quite well on rituximab treatment alone. Um, there are s- there are one cases that I remember actually was have very refractory NMOSD that actually failed rituximab. The lady was effectively blind in both eye and also paralyzed from the myelitis attack. I remember this patient, they start to give her eculizumab because this has been proven to be the most effective treatment for NMOSD, and also it works in patients that fail rituximab. However, the cost itself is so high that even Australia find it difficult to continue the treatment. The dosing interval of every 2 weeks is, as you can see, is very troublesome for a patient that is wheelchair bound to come to hospital every 2 weeks. So I think that's the reason why the drug company come up with the medication, the ravulizumab, which is a 8 weekly dosing, which I think is more sensible in that sense. But the cost is still quite prohibitive, even for Australian government.
I think we are still dependent on azathioprine, CellSAP, or mycophenolate, and rituximab, right, Chu?
Yes.
It looks like the newer FDA drugs seem quite a distance in terms of access for us, right?
Yeah, in terms of cost, they are definitely uh, a lot higher than our traditional immunosuppressant. But I would say, fortunately, most of our patient NMOSD in Malaysia, they do quite well with azathioprine or even rituximab. In fact, so far I haven't encountered anyone that is refractory to to rituximab yet, luckily.
I agree. I notice from all what you've presented, we do not have an oral yet, right? We do have one subcutaneous.
Mhm.
I guess we wait and see. Are we up for time, Dr. Liu?
Yeah, I think it's almost time already. I think if there's no more question, we can end the session today.
Yeah.
Thank you,
Thank
Dr.
you,
Chu. Thank you, Dr. Joyce.
Dr. Chu and Dr. Liu.
Thank you, Dr. Joyce. Thank you, Dr. Liu.